I have to say when I saw the topic, the title, I got a little bit of a panic attack. It's a kind of waffly thing, but it is a very essential thing. I'd have preferred to do something more tangible, but I agreed, so I'm going to have a stab at it. And I have to say, in researching and reading it, I actually learned quite a bit. So first of all, let me explain who I am and what I do. I'm not a GP. I'm not a normal GP. I do work in primary care, but GPs are generalists by definition. They're the consultants of everything. I work in general practice, but I only treat people in the areas of sexual and reproductive health. So I have the luxury of being able to say, oh no, I don't want to deal with that. So as a non-general general practitioner, I always feel like I'm a bit of a sham when I talk to GPs or about GPs, because I don't have to deal with what they have to deal with. The multitude of topics, to be knowledgeable and competent in all of it, I can pick and choose. And I am continually amazed by how well they do it with very little support. In some cases, they deserve enormous respect. Clear communication with patients is the foundation of all aspects of healthcare delivery, but probably particularly when it comes to screening, health screening, and the provision of women's health. GPs are still considered one of the most reliable sources of information, with a IMT survey, 91 respondents saying that they continue to consider the GP as one of the best and most trustworthy sources of information. Communication, of course, is the cornerstone to developing clinical skills. It takes a lot to communicate effectively as a GP or as a nurse. You have to know what you're talking about. You have to be able to consider the issue from the patient's perspective. You have to have some interpersonal skills. You have to be honest and transparent in your discussions. You have to show that you're committed to the welfare of the patient, and that should be evident at all times, and that's a really, really tall order. Communicating and teaching communication is not so much a science as it is an art, and it's a really difficult art to achieve excellence in. I've been a teacher with the Royal College of Surgeons Medical School for over 14 years. Among my 62 other jobs, I talk to graduate entry and leaving cert medical students from month one of year one of medical education. I teach them how to speak to patients, develop a relationship, take a history, do an examination, and then present that stuff back to them in a reassuring way. It's been wonderful fun. I think I learned more than I taught. I know everybody says that, but it's the God's honest truth. I was a much worse doctor then than I am now. Good to know. But I'll tell you, it's not always easy. Some people are not natural-born communicators. Some medical trainees, they have to gain confidence to sit in front of a stranger and talk to he or she in an intimate way, conveying care and compassion while desperately trying to remember all the science, all the algorithms, all the guidelines, all the mnemonics. It's very, very challenging. I have had times where I have spent an entire morning addressing how to make eye contact, how to shake somebody's hand, how to introduce yourself in an intelligible way so that the patient can reproduce it. And what Rachel said is so interesting, because that's not something they're all capable of doing. Finding out what the patient expects of you, telling them who you are and what your role is. And then the other hurdle is you have to do all of this while there's a rowdy queue forming outside the surgery door, because we're under enormous time pressure in medical care. So when discussing health screening, a healthcare practitioner does need a few couple of basic essential skills. They need time, they need knowledge, and they need a certain amount of numeracy capability. So with regard to time, and I don't want to get too snotty because that's not what we're here for today, but effective communication has never been more challenging in general practice because time has become such an enormous issue. GP funding has been slashed ever since the recession, and the promised restoration of those monies has never been acted upon. The current GMS contract is 48 years old. It is unworkable and unfit for practice. In 2015, GPs were assured that those issues would be resolved immediately, and on foot of that, the GPs agreed to offer free medical care to all children under 6, in spite of already being overstretched. We continue to do that, but no GP contract has been provided. And the massive extra workload has stretched general practice to virtual breaking point. In many areas of Ireland, you can't get a GP. In rural communities particularly, patients are not getting GPs, neither private nor public. It's not safe. It's not a workable system. Many practices are without doctors because there's nothing to attract a young GP to this kind of lifestyle, in the surgery day and night, going in on the weekends to catch up with your paperwork. Luxury of a meal break is a memory. Toilet breaks are still important, but we don't take too many of them. The job is immensely pressurized, and that's not confined to general practice. I'm sure it's in all walks of medical health. So in this context, with the malaise that have overwhelmed general practitioners for so long, I don't want to be patronizing. I don't want to talk about how good we are at clear communication when we know that we don't have the luxury of time. With regard to knowledge, you need to offer cancer screening consultation in such a way as to let the patient know both the purpose of it and the limitations of it. And again, that's hard to do in a short amount of time. There is a world of difference between a diagnostic evaluation of a cervix and a cervical screen test. I run a service for GPs online through a company called GP Buddy. So anybody with a medical council registration number that identifies them as a GP can email me, and I give timely advice about challenging patients. The number of GPs who write in and ask me about cases where a woman has attended with a gynecological complaint, pain, irregular bleeding, vaginal discharge, urinary pain or frequency, and the doctor writes in the inquiry, well, I did a smear and it was normal. I want to jump down the laptop, find them, and say, what the heck were you doing? What was the purpose of that? Do you not understand what a smear test is for? You don't know the rules, okay? Smears are not for symptoms. They are only useful to identify cell changes that might herald the risk of a future disease and are in no way indicated for the investigation of a woman with gynecological symptoms. Women with symptoms, abnormal bleeding, persistent discharge, all the other stuff we said, they need to be seen in a diagnostic consultation capacity and possibly sent for further investigation. And regular smear testing as a diagnostic intervention is completely inappropriate, but it happens. And now I'm going to stop yelling, and I apologize for that. Numeracy is a big issue that I struggle with myself, okay? Maths is hard, and we didn't all do good maths in the Leaving Cert. Okay, we had some basic statistics courses, but there's a huge amount of stress and difficulty interpreting and reading studies and then feeding that information back to the patient. This idea of collective statistical illiteracy and innumeracy is actually not a joke, it's for real. And I have a little slide. Now, this is a personal bugbear, and I won't take too long because I know we're limited for time. But these are cases where studies were interpreted in such a way by both media and healthcare that they caused enormous patient harm. In 1995, I was working in a family clinic in Calborough Street, and I think it was the UK Committee on the Safety of Medicines sent out a Dear Doctor letter, but then of course it appeared in the Evening Herald, saying that some research said oral contraceptive pills containing the more modern types of progestin double the risk of heart attack. Double the risk of blood clots, and that was absolutely true. It went from virtually nothing to twice virtually nothing. But the media ran a headline, modern pills double your risk. Significant numbers of women just came off contraception altogether. Our phones were jammed for weeks and weeks. We had to hire new staff. A substantial increase in the number of unintended pregnancies resulted, particularly significant in the younger, more fertile women, obviously, and many, many extra unintended pregnancies in the UK and Ireland resulted. Now, of course, we don't know all the data for Ireland, but I can tell you the NHS has calculated that one publication cost the NHS 21 million sterling additional for the year 95-96 in maternity care, and 46 million pounds sterling in abortion provision because of one headline. So interpreting statistics, it's hard, and it's not for lay people. It's only for people who know what they're doing. Another very personal issue with me, because I'm a menopause specialist, is the nonsense spouted by the 2002 Women's Health Initiative publication, where it has become part of the collective knowledge of the world that HRT causes breast cancer. Nothing could be further from the truth. If you never took HRT and you're between 50 and 60, you have about a 23 per 1,000 mammogram rate of getting breast cancer. If you took HRT, yeah, After 5 years, it does go up slightly, but not as much as drinking a glass of wine every day does. And look what obesity does. Meanwhile, I can't give this crap away because people are so afraid of getting breast cancer from it. And it is a very important strategy for older women. So again, rant over, but that's the importance of knowing your statistics and knowing how to interpret them for people. So please keep it simple. Use pictures, use real terms, use absolute risk, never relative risk, because that's what makes headlines, that's what scares people, and it doesn't convey information. As far as screening is concerned, Dr. McKenna said when addressing the eructus, there's a lot of hurdles. Cervical screening particularly is really, really hard. First of all, we need to get people to come in, and we know that the uptake is far from 100%. Maybe what we were talking about with self-screening and self-taken smears might actually, or HPV samples might actually help turn that around. We need to explain what we're doing and what the limitations are, and that takes time. We need to know what we're doing ourselves. You know, cervixes are hard. They can look funky sometimes. Like, there's a huge variation in what normal is, and you can't be sending everybody to colposcopy, but you should know a healthy from an unhealthy cervix. Cervical cancer is so rare that a lot of GPs will go their whole lifetime and never see one. So it doesn't necessarily follow. You got to do your smear taker course, and you got to update. We need to be able to put the precious cells in an adequate travel facility. We need to hope that they're going to be processed efficiently when they get to wherever they're going. And then we need to be able to explain the meaning of a negative result, the meaning of a positive result, and follow up if abnormalities are detected. And that's an awful lot to do in the about 10 minutes that you have to offer a smear test. So what else can we do? Well, as far as not attending, maybe self-selection will be helpful. Maybe that'll be a good thing. Some women just don't come, and I think a lot of it is anxiety about the test itself, what it's going to entail, how painful it might be, and believe me, some people go through a lot of discomfort. Some people in Ireland are extremely body shy, you know, and it is Ireland, it's unique to this place. We have the lowest per capita sales of tampons in the Western world. Irish girls are not very vagina friendly, so when we ask them to get up on the couch and have an intimate examination, a lot of people don't want to get involved, and I totally appreciate that. Sometimes it's more serious than that. Some people have been traumatized, either by a bad smear or a genital assault, a sexual assault. Some women have been victims of female genital mutilation, and they don't want us to see what's going on down there. So all of these things have to be teased out. She may not come because she's afraid of what you're going to find, and that is a big factor. A lot of people think no news is good news because the anxiety, as we were talking about, is almost as bad as the disease itself in some cases. So that's a really important thing. Women may not remember everything we tell them and all the rest of it, but they certainly will remember how they're treated and how we make them feel. And then when trust is developed, they'll come back and they'll follow advice. So there's some quotes just from UK people. I actually didn't have your survey, Rachel, so I wish I'd had that. But anyway, these are just UK quotes about how people felt about smears and things like that, you know. So remember, when you're talking to patients, when we're talking to patients, it's ideal to not roll out the charts, not roll out the statistics. We want to tell stories. We want to use parables. We want to personalize it as much as possible. That old style condescension where doctor is up here and patient is down there is unacceptable, and it has gone out a long time ago. I don't think the message got through to everybody, but that is the office. You offer advice based on what you would tell your own family and your own friends, and then try to keep current, although that's easier said than done in the current situation. So finally, you got to keep training. As I say, especially with regard to smear tests, where there's a lot of clinical skills involved, you need to have gone through conscientious training. You have to go back on a regular basis because things change. Thankfully, during all the cervical smear controversy, uptake hadn't actually dropped. In fact, if anything, it went up, as we know, because there's now like a 3-month delay in getting results back. But anyway, and even the reluctant women who had never attended before, have actually started to come in, possibly on foot of the cervical screen situation. So I just want to say one thing before I end. I read the Scally report as well, cover to cover. I didn't do it in 20 hours, though. It took me about 3 weeks. But anyways, he says in his extensive report that there's a huge concern with paternalism in the health system, condescension. And I agree, and I think it's inexcusable. We need to eradicate that. It's probably one of the main contributors of the shortfall we see with women's health and reproductive rights in Ireland. So no more condescension, no more paternalism. I agree with him when he recommends that the Minister for Health should give consideration to how women's health issues should have more consistent, expert, and committed attention within the health service and the Department of Health. He talks about grace and compassion. I mean, those are key words, really. And I think that we in primary care are all too well aware of the importance of those concepts. It is not good enough to be a good diagnostician. It is not good enough to be aware of and follow all the many healthcare algorithms and the guidelines and the best practice recommends. You need to do the whole thing competently, but you need to deliver your craft with grace and compassion. And hopefully, the lessons we learned today will help us do that. Thank you very much.